Welcome to Real Health with me, Karl Henry. Folks, every minute counts in a stroke. Recognising the signs and acting fast can be the difference between full recovery and a lasting disability. Professor Ronan Collins, HSE Clinical Lead at the National Stroke Programme, joins us to highlight why time is brain, what warning signs to watch for, and how rapid action can save lives. Professor Collins, welcome to the show.
And thank you for having me.
Stroke it's very important to talk about it, isn't it? We have a huge prevalence of it in Ireland.
It is. I think really people don't realise this maybe but your lifetime risk of getting a stroke is 1 in 4.
1 in 4?
Yes, so stroke is a very common event. Obviously that risk increases as you're getting older for many different reasons, but very simply put because your heart and the pipes to your brain are getting older and affected by what we've done during life. And so that's one of the main reasons it's age-related. But about a quarter of our strokes occur in younger people, and the mechanisms there are usually kind of diverse. And so a stroke isn't as straightforward, I suppose, from a conceptual point of view, like a heart attack is, in that a heart attack is typically caused by an artery to the heart muscle blocking. Whereas in stroke, it can occur for many different reasons, either the vessel in the brain itself being diseased, the vessels to the brain being diseased, the heart chambers being working ineffectually, or having diseases of the valves, or people having congenital issues like a hole in their heart. So there's many reasons why a person might get a stroke, but broadly speaking, there's 2 main types of stroke. If you think of it like pipes within your brain, the pipe either blocks, which is the commonest version causing an ischemic stroke. About 85% of strokes are ischemic due to a blockage, a clot blocking the artery. And then the remaining 10 to 15% are due to a pipe bursting, causing a hemorrhage within the brain. So they're the 2 common mechanisms. But our treatments for either type of stroke are more effective if they're delivered quickly. And that's one of the key messages we want to get across to people, to attend the emergency departments, to ring 999 and follow that pathway.
And chat to me about the early warning signs of a stroke, both maybe to someone having one and someone who may see one, if that makes sense.
Yeah, absolutely, of course. So we concentrate, and I'm sure that people will have seen the adverts we're running on television. We put a lot of thought into the adverts. We wanted to get 2 messages across. Number 1, that stroke happens maybe to slightly younger people than you might think it happening to 2. So I think it can happen to anybody at any time.
A lot of people think it's always, that's 60 or 70, and neither of which are very old, by the way. That's important.
Yeah, no,
important to say.
Exactly.
But it can happen to. I came across a case over Christmas of a 40-year-old who died from as a result of one.
Yes, that's
incredibly young.
That tragically happens on occasion. I think the youngest stroke personally I've had was 18. Wow. And there are pediatric strokes that happen as well. Of course, that's important to recognise. But the key messages we want to get into people's heads looking at the adverts is that could happen to anybody. The lifetime risk is 1 in 4. It's quite a common illness. And then the second thing we wanted to get into people's thought processes was that it could happen when you're doing normal lifetime things, like being at a birthday party, playing tennis. And so to concentrate that just because you get a symptom, not to put over context on what you might be doing at the time is, that explains it. Do you know what I mean? A stroke can happen at any time. The cardinal most common features are recognised by the acronym FAST. F for facial weakness. So if you see a person's face suddenly dropping on one side and becoming weak, or you feel that yourself. Arm, if your arm goes clumsy or weak or appears to be.
And is it a particular side? Is it left?
No, it can be either or.
Oh, okay.
It can be either or. Speech. So if a person's speech is either slurred, as if they're suddenly trying to struggle, or they're not saying the words correctly. They're using words that are, if in some way, like kind of paraphrasing what they want to say, like saying maybe jug for cup or something like that. That can be a clue that a person is experiencing a stroke. Now, they are the commonest symptoms of a major type of stroke, but there are others.
The word change, I'm intrigued by that now, because there were lots of people listening in who might think, geez, I couldn't remember the word over Christmas for my my in-law or whatever. Like that's something that happens to people a lot.
Oh yeah, that happens.
Generally.
That sometimes happens as we get older. Word retrieval problems.
It happened
Sometimes
to me in December. That's why I'm bringing that up. I'm like,
sometimes it can be a sign of an underlying cognitive problem developing. But I think we all have slip-ups.
it was the weirdest thing. I was writing something for someone, and literally, for the life of me, I could not remember the name of the person, and it took me a good 60 seconds to get to it.
Get to it. Yeah.
Anyway, there we go.
And we all get those.
I know other symptoms, thank God.
We all get those transient ones. But I think the speech problems in stroke you'll tend to find are kind of, people will say they'll either make a phonemic error, like that they'll say shop instead of cup.
Yes.
That's a phonemic error. Or they'll make a semantic error, like they'll call jug instead of cup.
Yeah.
But also to understand that people may have difficulty understanding you. That they're not understanding receptive aphasia, not understanding the language. So 2 major types of speech problem: expressive, where a person can't say the word; receptive, where the person can't understand what is being said to them. But so that facial weakness, the arm weakness or clumsiness, the speech, sudden onset speech problems often signify that this is a stroke in evolution.
And with those symptoms, are they transient, or do they? My point, you're saying earlier, but the situational idea that people think may kind of did say, "Oh, that happened because I'm in this situation." Did they stick, or could it happen for a minute, 2 minutes, and then?
Yeah, so people will be familiar with the term mini stroke or TIA, transient ischemic attack. But those transient events are often like the quake before a major earthquake, and we don't want people then they've got better. Oh, that's grand. It's you should have a high degree of suspicion if suddenly happens, because stroke is always sudden. It doesn't really come on gradually, because the vessel either blocks suddenly or ruptures suddenly. Now, apart from face, arm and speech, and I do want to say this to the public because I know many people will be listening and say, I had a stroke and I didn't have that symptom. Depending on which part of the brain is affected, other symptoms can happen. But in public messaging, it's very difficult to give people a huge menu of things. But I suppose I would recognize the other common ones are a sudden onset of a visual problem, like loss of vision in one eye, or sudden onset of double vision, seeing double. That should alert you that there might be a problem. If there's a sudden imbalance, i.e. you're very suddenly, your walking goes off kilter and you can't maintain your balance, that's called ataxia medically.
There's one word you've used now quite a bit, sudden.
Yes.
That sticks with me, that it's not a gradual,
No,
it's sudden.
Sudden. Stroke is a sudden onset of symptoms. Because the vessel occludes suddenly or it ruptures suddenly. And then the last very common one is people who suddenly get the worst headache of their lives. Because that often means that a pipe is ruptured and that there's a sudden expansion in volume. And I say this particularly to people, sometimes people, and it's a common thing we trip up on in medicine, particularly people who may suffer with migraines periodically. But if this headache is different and more severe, and you will experience it as being different and more severe, it is important to seek a medical opinion on it.
And are men or women, is there a difference in terms of who's at risk more?
There's a slight preponderance for men, but it's only slight. Overall, there's not a massive discrepancy in that regard.
Chat to me about time is brain. The phrase, I like it.
Yeah, time is brain. We want the T in fast means act fast. Don't hang around. Don't ring your mother and see what does she think. Don't ring your brother in the States to say, have you ever had this happen to you? Try and maybe not go to a general practitioner either. Ring the ambulance, and the reason also ring the ambulance. The reason ring the ambulance is important, the ring 99, is because we have set up the pathways whereby our paramedics in the National Ambulance Service and in the metropolitan area of Dublin Fire Brigade are trained to assess and recognise stroke, and they will pre-alert the hospitals receiving you. So on a 24/7 basis, we have a pathway for acute stroke care across all our hospitals. You won't be waiting in the waiting room. We don't want to put people off. If you suspect you're having a stroke, ring the ambulance. We'll take it from there. No one will be more delighted than us if you come down and we say, listen, we've done the scan and reassure you it's not a stroke. But don't take the risk with your health on
And
this.
when you go in there, if people go into hospital, what scans are done? Is it an MRI or is it?
No, so to diagnose stroke quickly, the first thing we want to do is to exclude that it's a bleed, and a CT scan is best for that. So we do a CT scan and we do a CT angiogram, so we visualize the vessels from the heart all the way up to the brain. So that allows us to determine, number one, whether it's due to a blocked artery or a ruptured artery, and that determines our treatment processes from there on out.
And chat to me about then the preemptive stuff that we can do from a lifestyle perspective to prevent stroke. So you're saying 1 in 4 is the
lifetime
number,
risk,
is the risk factors. What can we do then throughout the life cycle to prevent the risk factors?
Well, maybe I should be asking you. You're the expert in this field rather than me. But I suppose to say to people that we do have a national stroke strategy, and the prevention arm is a very important pillar of this. I could say in general terms, people should not smoke. People should exercise regularly. People should eat a healthy diet. And people should kind of also watch their mental health and stress levels, because stress does cause cardiac events and does cause stroke. But if I was to pick one medical thing to concentrate on, which all of those things lead into, it's blood pressure.
Oh, yeah.
Because I don't think people conceptualize blood pressure as to what's happening. If you think of your heart beating and producing a wave of pressure, that pressure has to dissipate. In normal circumstances, the vessels are like a new garden hose you've bought. They're pliable. They can expand with the force of the wave of pressure to dissipate it. But through the development of kind of premature aging of our arteries, very often that wave of pressure is delivered like a slap. And so if you think of that slap of pressure hitting your brain, hitting the back of your eyes, hitting your kidneys, blood pressure is probably the single most important determinant of how you're going to age. Because a lot of brain disease, most importantly stroke, but also dementia, a lot of age-related visual loss at the back of the retina, a lot of kidney failure in later life, which is a massive and growing problem. And of course, a lot of heart failure, because the pump has to pump against this high-pressured system, are down to people having undiagnosed high blood pressure.
And remind us of the regular blood pressure numbers.
Well, I think increasingly in the latest guidelines of the European Society of Cardiology, we now recognise pre-hypertension. Mm-hmm. So when we start seeing people, particularly without established disease, with blood pressures between 125, 130, we kind of recognise them as a people that need to watch or maybe pay attention to it. Certainly once you get over 130 systolic, we now would focus on you as having kind of, establishing hypertension and look at it as a kind of a pre-stage 1 hypertension.
And is that something that I know I have for work, but we have it at home just because it's handy to have, that people should have the home monitors and be checking their blood pressure kind of on a regular, like they should, if they're weighing themselves once a week, they should check their blood pressure once a week.
Yeah, I think the home monitors have been an important breakthrough.
Yeah.
I think there's an increasing recognition of the utility of them, that they get around a lot of the white coat element as well once people become comfortable taking their own blood pressure. I think it's a good idea to know what your blood pressure is, either by visiting your GP or by taking it yourself. And of course, our blood pressure fluctuates a bit. I mean, don't take it just when you've been out and you've ran kind of 3 or 4 miles.
Yeah, or had a row with your spouse.
Exactly.
Yeah.
That doesn't happen, does it?
Never. Never.
But, so you have to recognise that. Yeah. But I think people should look at their blood pressure and certainly see if that their average figure is above 130. They need to visit their doctor and have a chat about it.
It's a couple of readings at a time, isn't it? If you get a high reading, you do 2 or 3 after.
I usually tell people, pick a time of the week, the same time every week. Pick a time when you're relaxed. Sit down, take you're breathing 3 times and kind of record the middle one as being reflective of what it probably is. And then bring that record with you to your own doctor and say, listen, these are my readings over the last 4 or 5 weeks. You can see my systolic, which is the upper reading, is persistently above 130. Should I maybe start a medication? And then usually there will be discussion about lifestyle as the first instance, particularly about your diet and the relative intake of sodium, salt, which is the bad electrolyte here, and potassium, which is the good electrolyte here. And what's new in the latest guidelines as well is to encourage people to increase the potassium intake in their diet because it relaxes the smooth muscle in the blood vessels. So things like fresh fruit juices, vegetables are high in potassium. Bananas, many people would know bananas are high in potassium.
And the monitor that we've an Omron one. I'm not sponsored by anybody. It's got Bluetooth on it.
Yeah.
So it talks to the app.
Yeah.
Wirelessly, and then if their readings are fine, but if they weren't, we have a record of all the times we've measured it on the app. It's brilliant.
Yeah, I know, it's fantastic. And increasingly, I've seen some very nice wearable wrist sensors now, which will give you a reasonable, reliable indicator that what your blood pressure is, and that can be a very useful clue as well. I'm loath to create health anxiety with people. And I'm not sure that wearing a monitor all the time is necessarily good for you.
I agree with you, by the way.
Yeah. But I do think knowing what your blood pressure is important. Now, I suppose if you asked me this maybe even 10 years ago, I would said, once you're in your 40s, you should know what your blood pressure is. I'd really pare that down back. I'm now beginning to understand that even people in the latter half of their 20s are beginning to develop the processes that cause hypertension.
It's basically something like everyone should, we should know your weight, you should know your muscle mass, your fat mass, and you should know your blood pressure. They're the 4 things to know. Brilliant.
Absolutely. But if you have a family history, because there is a genetic element to blood pressure.
Talk to me around the if you've had a stroke, the repercussions of that, or the treatment of that afterwards.
Well, I suppose in the immediate phase, we're trying to do 2 things. Number one, if a person has had an ischemic stroke, we're trying to open up the artery. We try to achieve that in 1 or 2 ways. Number one, by administering a drug that dissolves the clot. So if you think of pouring, I suppose, Domestos down a blocked pipe, that type of approach. And then in certain instances where we know by the nature of the blockage that that's probably not going to work, we have set up centres where we go after that blockage, again using the analogy of the block drain, with like a dino rod to pull the blockage back. That's not something.
You have a great way. Can I just move very early further? You have a fabulous way with words. You have a lovely way of talking about medical stuff in a really very simple way about pipes and clogs and dino rods. But anyway, go on. Sorry.
Well, no, I think it's important that people have if you like, an image of what's going on, because otherwise it becomes kind of like
it's great.
It becomes difficult to conceptualize, and so again, hopefully that will encourage people to seek attention early, to realize that we can do something, that the pathways are set up to achieve this, and then in terms of hemorrhage, we do important things. That number one, if people are on blood thinners, that we may reverse the effects of that. But controlling the blood pressure to very rigorous levels when a person's had a bleed into their brain is very important. And we're running important trials at the moment looking at anti-clotting agents as well to help people with intracerebral hemorrhage. And then there is a small but very important role for neurosurgery as well in certain types of hemorrhages, and indeed in certain types of ischemic stroke where the brain has begun to swell early. So we all work as a joined-up team. In the stroke community, between the stroke physicians and neurologists, and also with our thrombectomy interventional neuroradiologists at Beaumont and Cork, and indeed our neurosurgeons at Beaumont and Cork. And of course, this pathway is very much dependent on the patients, number one, recognising that they're having a stroke, our colleagues in the National Ambulance and Dublin Fire Brigade in activating that pathway, and then all our colleagues along the way who, Porter staff who take patients into scanners and emergency, all our radiology staff and radiographers. It's a real team effort, all our nurse specialists, etc. So that's the acute phase of stroke. All stroke needs to be managed in an acute stroke unit. acute stroke unit improves the outcome for all types of stroke at all ages. One of the deficits across our system is we do not have enough acute stroke unit beds, something we're trying to tackle. But I have to say this, 1/3 of our patients do not get into a stroke unit, and that's not acceptable.
1/3?
Yes.
Wow.
That's not acceptable. And that's something that really needs to be. I've been trying hard as the clinical lead to get people onto the page about this. I don't think anybody would accept that if I had a heart attack, I wasn't being managed in coronary care. We should have the similar, if you like, intolerance to the fact that I've had a stroke and I'm not in an acute stroke unit. Because acute stroke unit, number one, prevents the complications that happen after a stroke. Number two, you promote the early recovery and education of the patient about what's happened to them and what needs to be done, and starts that first phases of multidisciplinary assessment and rehabilitation, because the majority of patients who have a stroke, we may lessen the effects of it, but the majority will be left with some form of physical impairment that we need to remedy. And it is the ambition of the stroke program not just to rehabilitate people, but to restore people to life. And that means holistically setting high bars and getting people back to the life that they had. Not always achievable, but you have to set the bar high and not accept a lesser form of recovery when we can do better.
It's important to say that there is life after stroke.
Very importantly, there is.
Yeah, and how crucial the rehab work is.
Yes, and it's very important. There will be an adjustment after a stroke, even if you are not left with physical impairments. I mean, psychologically, you've had a big brush with a life-changing event. And that will cause people to reflect. It will cause anxiety, health worries, changes in the nature of relationships, may involve changes in people's occupation, vocation, effects in things that they can and cannot do. So it is a huge impact on a person's life. It's like a meteor landing and smashing into you. And so the restoration to living phase, there's an acute phase to it, but we also increasingly recognize that people need support afterwards into the community, and very importantly as well, the psychological support to come to terms with what's happened to them.
What key takeaways would you like people to take from the episode?
I would like people to know their blood pressure. Please know your blood pressure and educate yourself about that.
Every episode we take a very important clip and use it for our Instagram promo. Your blood pressure clip will absolutely be that one, because it's a really important point, and the fact that it's as important as knowing your weight or your muscle mass is and we will amplify that everywhere. Yeah,
in my opinion, it's the single greatest determinant of how you're going to age. On your brain, your eyes, your heart, your kidneys, which are key issues, are key organs for us going forward. So blood pressure, know your blood pressure, know how you can control your blood pressure through your diet, eating a diet rich in potassium, low in salt, exercise regularly, and keep your weight within healthy levels. Avoid alcohol excess, which increases your blood pressure. And very importantly, I think I need to say this in the current environment, please don't use cocaine. People don't realize, but you could be the unlucky person. Cocaine does have effect on blood pressure, but in the acute phases, it very often causes the artery to go into a spasm, either in your heart and in your brain, and it's a frequent cause of stroke in young people, and it can be a very life-changing event for you. So please be aware of that as a factor.
We had Professor O'Gara in with us just before Christmas, I think, chat about the prevalence of, oh my God, it was a mind-blowing conversation around the prevalence of cocaine abuse and use, and it's incredible.
Well, it would seem that way. I mean, I've walked into so many facilities in bars and stuff over the last number of years. Not that I'm out that often, but the few times I have walked in, I've been struck by seeing the telltale signs of little bits of powder, people hurriedly blowing their nose as they come out. So it must be widespread. It must be
scary.
Yes. Yeah.
Well, hopefully we will save some lives with today's episode. Thank you so much for coming in.
No, and thank you for the invitation. I think it's a very important message. I would like people, please go onto the HSE websites. We've got a good web page about stroke and about blood pressure, but also to become educated on something that is very common, a lifetime risk of 1 in 4.
Fabulous. Thank you so much for coming in. Folks, that is it for another episode of Real Health with me, Karl Henry. As ever, you know where we are at Karl Henry PT on Instagram, Real Health at independent.ie, and on the Irish Independent website. We'll see you next week for more Real Health. Slán go fóill.